topic. I know that most surgeons have not put an arthroplasty in the lumbar spine, not even thought about it, or maybe consider it totally unrequired. For over 80 years, the gold standard for discogenic low back pain, when everything else has failed, has been a lumbar fusion. However, it alters the biomechanics of the spine, and it causes adjacent segment degeneration. At least that's what we think happens. And most of it is not symptomatic, but some of it does become symptomatic. And we're worried about this, especially in the younger patient. Or is it the natural history? We don't know. Starting in the 1980s, the total disc arthroplasty, again, the concept, as mentioned earlier by one of my colleagues, came out of the arthroplasties in the hip and the knee and the other joints. So to preserve motion at the same time as basically exchanging the painful part of the body. So there are quite a few, there are 4 that I'll be talking about today, because these 4, each one of them has a randomized control study, an FDA-approved randomized control study. All the previous studies, they were not trials, they were case series. Most of them were based out of Europe, mostly in Germany and France. And they've showed reasonably good results after total disc arthroplasty for the appropriate patient. However, they were not controlled, definitely not randomized. Some of them have long follow-up, up to 10, 17 years, actually, some of them. But these studies, these are excellent studies, randomized controlled trials, and one of them has a 7-year follow-up. Most of them have 2-year follow-ups. And these are the ones I'm going to focus on, because these are the highest grade evidence available for this prosthesis. So, what would you like to know? So, is it equal or better than a lumbar fusion? Are the outcomes just as good? Is it safe? Are the complication rates low? Reoperation rates low? And does it prevent adjacent segment degeneration? I think this is the hardest question to ask, and this is still the one that you will see shortly. I don't think it's answered yet. So the first study I'll be talking about is a study published in Spine 2007 about the Prodisc arthroplasty. It's a randomized controlled trial, FDA trial, 236 patients, many centers. Prodisc versus femoral ring allograft, so anterior lumbar interbody fusion, with iliac crest graft, so including basically an iliac crest incision. So 2 incisions versus 1 incision. Now, indications, that's probably one of the biggest questions around this procedure. Which patients should be included? This is their indication, and the rest of the trials, they have very similar indication for surgery inclusion exclusion criteria. So if you can see here, so these are the patient age spans everything, but they're usually on the younger patient. Single level disease, they have a lot of pain, they failed 6 months of conservative treatment, and basically they need not to have facet joint disease, they need not to have any metabolic bone problem, and they could have leg pain, but they need to be basically having all these inclusion-exclusion criteria. So how did it go for these people? How did they check it? They did validated outcome scores, OSWES-3, SF-36, pain scores, satisfaction scores, neurologic examination, and radiological examination. And they followed up these patients for 2 years. Now, we don't have long follow-up. 2 years is what we have. These studies in another 5, 10, 15 years, maybe then they'll give us more information about adjacent segment degeneration. They had reasonably good follow-up rate, about 90% for both control and study group. So, how about the numbers here? So if you look at the numbers in terms of intraoperative and just basically in terms of blood loss and hospital stay, so you'll see that basically, because again, they state that in the study itself, there is a learning curve. The surgeons needed to learn it, so they took more time, there was more blood loss, and the length of hospital stay was actually more with the prosthesis than it was with the fusion procedure. So what matters is, does it relieve their pain? And yes, it does. And there is a tendency, there's a trend only, it's not significant, that the total disc arthroplasty has better outcomes. The pain scores were no different between the two. Satisfaction was higher, and you'll see that trend with the other studies too. Satisfaction tends to be higher with total disc, maybe because the patient already knows that he has the brand best technology there is out there. Now, the reoperation rate was kind of similar, a little bit more in the control, and the principal reason for reoperation in the control was prominent hardware, which needed to be taken out. No difference in narcotic use. Return to work, again, not much of a difference. Complication rates, not much of a difference, pretty much the same. Overall success, fairly close to each other. So this is one of the first trial. There was a trial about the Charite arthroplasty, but I'll talk about it later because it has a longer outcomes, longer follow-up period. So there were clear inclusion exclusion criteria, detailed sample size analysis, that they did their homework pretty well, validated measures used, good follow-up in both groups for up to 2 years. The problem I'm having, and a lot of people are having, are we comparing two similar to things? 360 fusion versus an anterior procedure. The 2 incisions, and in some cases, you'll see in the other study, 3 incisions versus 1. And the follow-up is too short to have any meaningful analysis regarding adjacent segment degeneration. We'll go to the next one. Now, this one's a metal-on-metal arthroplasty. The patient number is small, but still a randomized control trial, and again, 360 fusion versus total disc arthroplasty, and again, followed up for 2 years. Inclusion-exclusion criteria similar to the previous one. So true discogenic pain, and the patient had to be basically a candidate for the procedure, had to agree that he be randomized. The outcomes are similar. Surgical data and radiological view were done. Now here there's a little bit of a difference. The length of stay and the operating time were actually worse in the fusion population, which makes you think exactly what's going on. The opposite of the previous study. Now, what matters is the pain. Does it relieve their pain? And yes, it does, but there is no difference between fusion versus disc arthroplasty. Reoperation rate, little bit more in the control group, again, in the fusion population, and that's because mostly of prominent hardware that needed to be taken out. So this is the first study about a metal-on-metal arthroplasty. It had used validated outcome measures. The numbers are small, they're very small. There's no general health outcome measures like the SF36, unlike the previous one. There's no mention of patients lost to follow-up, which I really didn't like about this study. And the follow-up was too short to assess adjacent segment degeneration, again, similar to the previous one. All right, the 3 incision versus 1. Now we move on to probably the more important study. This is a study that had a lot of people talk about it a few years earlier when it showed no difference in the 2-year follow-up between anterior lumbar interbody fusion versus the back cage. Now, this is not the 2-year study. This is the 5 to 7-year follow-up study. 6 centers already withdrew from the study. 8 remained. Inclusion-exclusion criteria remained the same. Outcome measures similar to the previous studies with the ODI, VAS, and SF36. The rate of adjacent segment degeneration for the first time is actually explained in the study, although it's not meaningful, and I'll tell you why. The OR time, blood loss, and length of stay showed no difference. ODI, SF36, and VAS showed, again, no difference at 2 and 5 years. The earlier study did show a little bit of a difference, but that was only up until 1 year. After that, there's no difference. Return to work. Now, there's a little bit of a difference, but I don't know, it's probably not that meaningful. A little bit more with disc arthroplasty than it is with the fusion. Long-term disability, little bit less with not a little bit, quite a bit less with the Charite arthroplasty than it is with the fusion. Reoperation rates, very similar. And for the same reason, adjacent segment degeneration. So that probably answers most of the questions in your minds if you're still awake with me tonight. Radiologically, so range of motion is another reason. We are putting this prosthesis in to know if that disc actually moves. Otherwise, it's completely useless. So there was 8 degrees of range of motion. It was unchanged from preoperative. And adjacent segment range of motion did not increase. What does that mean? It means that basically that there wasn't any transfer of forces to the vertebra above. But that was regardless of a fusion or an arthroplasty. So this has the longest follow-up, and this is probably the only strength of this study. of this RCT. And this is probably what people remember, because the next one I'll be talking about, the last one I'll be talking about, is relatively recent, just in the past few months. It's been out. But there's a lot of patients that have been lost to follow-up, and it was designed for 2 years, and they extended it. So it wasn't exactly designed for that, and the loss for follow-up makes a lot of the analysis unremarkable. The back implant has been shown in other studies not to be a good implant, all right, not to have good outcomes. This is a recent study, just published in Spine recently. I think it's just a few months ago, maybe 2 or 3 months ago. And this is again another, so all the 3 previous ones are all different types of implants. This is another metal-on-metal implant. And this is a big trial. There's around 600 patients in this trial, and they had 2 to 1. So they had 2 patients going into disc replacement versus 1 going into anterior lumbar intervallar fusion. It started way back in 2003. There were 70 surgeons in 31 sites, and the control was the LT cage. So the approach varied according to the surgeon. It could be transperitoneal, it could be retroperitoneal. The inclusion criteria were similar, all right? But they didn't, this is wrong, they did include the patients with radiculopathy, and that's one of the issues they had. But so did the other trials. So the measures used were exactly the same: SF36, the ASWES-3, pain scores, mobility, return to work, and patient satisfaction. Follow-up, again, was for 2 years. So the results showed statistically significant superior outcomes for total disc arthroplasty, and again, that's for the 2-year follow-up. For the ASWES-3, I'll show you for the SF36, 70 versus 14-point improvements. Patient satisfaction, again, statistically significant. Return to work, 75 versus 96 days. That's probably the most important point out here, because the patients did go back to work faster with the disc replacement than they did with a fusion procedure. In terms of hospital stay, it was the same. OR time is a little bit longer, blood loss a little bit more, again reflecting the previous trials. Reoperation rate was more with the total disc arthroplasty. And most of the patients reoperated here were not for loosening or migration of components. They were for persistent radicular symptoms, and most of these reoperations came out of 1 center and 1 surgeon. So there is obviously a problem with probably his inclusion criteria. This is the principal table for this study. And again, around 577 patients, 100% follow-up for over 2 years. It clearly shows statistically significant improvement in the investigational group versus the control group, all the way down to 2 years. Radiological parameters were here shown, maintained in both. Interbody motion is preserved, actually improved with the total disc arthroplasty, which should be. And the ALIF, obviously, is close to 0. In terms of strength of this trial, it's a large trial. It's the largest trial to date. Unfortunately, it's still 2 years follow-up, and hopefully they won't lose most of these patients. They used the same approach, so they used 1 single anterior approach for all the procedures, and they followed up all of them for 2 years. The problem is what I'm having is I'm not sure that all of us will do an ALIF in these days for a discogenic back pain that fails all conservative treatment. But this is the one they used, and they had BMP inside the cage rather than anything else. The follow-up is too short, again, for any meaningful analysis about adjacent segment degeneration. And there is no mention whatsoever in that trial about what some orthopedic surgeons know is an issue with metal-on-metal arthroplasty, increased metal ion concentrations, and toxicity. So what does these papers show us? That disc replacement does have some advantages. Clearly, most of them showed quicker recovery, less disability, and most patients returned to work earlier and returned to their activities earlier. However, there were higher reoperation rates overall, longer OR time, more blood loss, implant failures, migration of components, and again, the issue with an anterior procedure, and especially in our population, in our culture, something like sexual dysfunction, retrograde ejaculation is a big deal and should not be taken lightly. Any questions? Questions until the end?